Okay, I am here to help you get a basic understanding of our Swan catheter. Like I said, this is just a basic understanding. If you want to get more heavy duty into the hemodynamics and what the actual waveforms look like and components of the waveforms look like, there is a advocate educational booklet that tells you everything you want to know about the swans. This is just basic for most people who haven't seen a lot of swans, who are uncomfortable with them. But yes, there are other resources if you want to get nitty gritty into all the details of the swan. So what are some of the reasons for the swans? We get swans that are going to help us guide therapies, most commonly in our open heart patients, but sometimes they'll come back from cath lab with a swan in place. They may want to get a better picture of how to tailor their therapies in someone with heart failure, some pulmonary hypertension, maybe acute MI with some cardiogenic shock, maybe optimize some diuresing. So that's some of the reasons, and we just want to give you the basics here. We just want to give you the basics. So what we're going to do is, I'm going to go through the different types of swans first of all. We have two main swans that we're going to see. We have a continuous cardiac output swan, which is this one, and then we have a manual. Then we also have a manual cardiac output swan, which is this one. Our open hearts will come back with the continuous. You may see the manuals in our open heart, you may see the manuals in our cardiac cath lab patients more often. So when they insert the swan is the best time to get a feel for what the different waveforms look like. Most of the time they're going to come back with the swan already, but when they insert the swan at the bedside, it will be like inserting another central line with a couple of different things to it. So our swan, the physician's first going to put in an introducer or a cordis. It's going to go up here, subclavian IJ, and when they put this in, after they get this in, they're going to take the swan, and the swan is going to be thread through it, through here. And then it's going to go to the appropriate place. The way they insert it is there is a balloon. There is a balloon on the end of one of the swans, and when they insert it, the balloon is inflated, and the physician may ask you to help insert it with inflating the balloon. And what happens is that little balloon inflates, and it carries with the blood flow throughout the heart till it gets to the right spot. So when the swan goes in, you're going to see the variety of waveforms. The first waveform you're going to see is a right atrial waveform or a CVP waveform. Now, like I said, we can get nitty-gritty into all the details. This is a basic understanding. So basically what you're going to do is you're going to look for two little bumps. Look for the two bumps. That's how you're going to recognize the waveform. And the second waveform that you'll see is a right atrial waveform. A right ventricular waveform. So it goes into the right ventricle. This is going to look almost like VTAC because it's in the ventricle. Think ventricle VTAC. There's a couple of things that might clue you into this waveform. Your diastolic number is going to be pretty close to 0. You'll get numbers of like 30 over 1, 28 over 0. That's going to be your clue. Most of the times, the only time you're going to see this is when it's inserted. But this is important to know because if your swan slips out of place, it'll be important to recognize this waveform so you don't have further harm to your patient. If you do see this waveform, we now have 24/7 intensivists. Probably the best thing to do would be grab one of them. If the patient is having runs of VTAC, probably you would want to notify them and have them come to the bedside, but if they're tied up in another room, as a nurse, we can withdraw the Swan a little bit until it goes back to your CVP waveform. We can withdraw, we just can't push forward. The next waveform you're going to see is a pulmonary artery waveform, and that's in the pulmonary artery, and it's going to look like an arterial waveform because it's in the pulmonary artery. And this is what we're going to see monitored on the monitor most of the time. The next waveform you'll see when it's being inserted is the wedge waveform, or the pulmonary artery occlusive pressure waveform. So this is when it's wedged in one of those little small vessels in the pulmonary artery, and it also looks kind of similar to a CVP waveform. Look for the two little bumps. Typically, we're only going to see this when it's inserted. There are times that a physician may want a wedge waveform. If they want one, we need a specific physician order for the frequency, or many times the cardiologist will just get it themselves at the bedside. Another reason why it's important to recognize this waveform is if the Swan migrates, you want to make sure that it doesn't stay in this position for too long because it can cause a pulmonary infarct. Also too, we used to get this number a lot more, but now the standard is we follow the pulmonary artery diastolic pressure. And they should be within a couple of points of each other, the wedge pressure and the pulmonary artery diastolic pressure. And we'll verify that when the Swan is inserted. You'll be able to get both those numbers and make sure they're just within a couple of numbers of each other. Okay, so back to the different types of Swans. Our continuous cardiac output Swan, when you take a look, I'm going to go through these different ports. So you've got a couple of different ports here. Like I said, this is going to be thread through the introducer, so you always have this port as a line. In our open heart population, what we do is we have a maintenance fluid along with our cardine, our antihypertensives, so in the open heart population. In a regular patient, you can use this as if you need to give fluid boluses, but typically in our open heart, we use this for our antihypertensives. The other ports you're going to see, this is your prox injectate. This typically is where you're going to have a maintenance. You're going to have a maintenance TKO line where your antibiotics, your IV pushes are going to go. In an emergency situation, all of a sudden your patient codes, where do you put your lines? Think blue, code blue. This is a good port to have open just to give your emergency meds. The next port I'm going to talk about is your PA distal. And this is where your monitoring port is. This is where your monitoring port is. And this is what you're going to see yellow on the monitor, and I'll go through that a little bit later. This is your proximal infusion port. This is a port that we will put any vasoactive medications in, your inotropes, your vasopressors in the open heart patient. If you don't have any of those, you do want to just have a TKO line just to keep the vein open. In our continuous cardiac output monitors, we'll have this. In our manuals, as you can see, you're missing the white port. So in the manuals, a lot of times if you have drips, this is probably a good place to go. The other difference between the two cardiac outputs is in our continuous, you have two of these thermistor ports. In the manual, you have one. The way the cardiac output is measured in the continuous, this little thing right here, it just sends readings back and forth, and that's how you get your continuous cardiac output reading. In the manual, the way you get your cardiac output is when you inject fluid in here, it comes out around here somewhere, and then the machine will measure how long it takes that change in fluid temperature to go from the Swan to the very end. And that's how it measures it. So another reason why you just want to have just a maintenance fluid, a TKO in here, if you're injecting fluid in here, you really don't want to have pressors in here. You don't want to give them a nice bolus of a nice little bolus of Levofed. That could cause a lot of problems in your patient. Okay, so to set up the Swan, you should have stopcocks in all these ports, just to make things go a little bit easier. So in all intents and purposes, I'm going to start with this one first. What we want to do is you want to have the pressure bag when they insert it, and this is basic stuff. This is basic stuff, but it's a good review anyhow. If you have a pressure bag for the Swan, you don't want to use this with the syringe because you don't want to be doing large volumes through the PA port of the Swan. So you're going to want this pressure bag or this pressure tubing with the pressure bag. So you're going to set up the pressure tubing like you normally would, and nice basic review for anyone. Set it up just like an art line. You're going to poke it. You're going to burp the bag, get rid of all the extra air, because when you get to the end of the bag, you don't want all that air to get to the patient. So, I have heard that if you prime this without the pressure bag, you have a decreased chance of bubbles. I don't know if there's any studies on it, but if you prime it without the pressure bag, supposedly you've got less bubbles. And when you're priming it, just put a little bit in here. You don't want to fill the chamber too full, because when you're checking to see the patency of your line by doing a square wave test, it would be hard to tell if you have good drops or not. Okay, so we're going to prime this. I'm going to get the fluid through there. And then you're going to put brand new stopcocks on there because if you take a look at this, these actually have a hole in them, so it's going to be an infection control issue. Okay, so stopcocks. You're going to put a stopcock on the end of each one of these. So you're going to put a stopcock on the end of this. And obviously, I haven't primed all this, but all this will be primed in the perfect world. All this will be primed in the perfect world. You're going to put your pressure tubing on the end here. And then you're going to go in here on your menu. You have, in here you're going to go ahead and set up your Swan. So on here, this is set up as an art line. When you go on in to set it up, you should have your waveform. Sorry, user error. Everyone knows me in tech. So when you go in here, you can label it to make it your PA, pulmonary artery. And then we want it on. So in a perfect world, you will have the yellow waveform here. In the perfect world, you'll have the yellow waveform here. And what you'll do then is you will make sure you got it zeroed at the right place. Leave a static access. You're going to attach it. To 0, you're going to go off to the patient, open to air, hit 0 on your monitor, wait till it shows 0, and then it's ready to go for the insertion. If they come back from cath lab with the Swan in place already, and all you have is the pressure tubing, a lot of times they will come back with, a lot of times when they come back from cath lab, they'll just come back with all your stopcocks attached like this and just maybe capped. They may just come back from cath lab with all this stuff just capped. So yeah, they may just come back from cath lab with all this stuff just like this. So you need to make sure you're putting in the appropriate things in here. In here, the TKO line, your code blue port, your vasopressors, and then in this will be only the pressure tubing. Only the pressure tubing. In order to get a CVP, we typically just monitor the pulmonary artery. In order to get a CVP, we use something called a bridge. I know a lot of people have a hard time just figuring this out, so I'll show you how to put the bridge. When you have your stopcocks, when you have your two stopcocks are going to look at each other when you put your bridge on. They're going to look at each other. The blue and yellow are going to look at each other. So you have your bridge. It's going to go from the yellow port, and all this will be primed with saline. And go from the yellow port to the blue port. So when you're monitoring on a regular basis, the fluid will be looking at your yellow port, your pulmonary artery. If you want to get a CVP, what you want to do is you want to look at what's going on here. So you close off to the yellow port. The fluid will look to here to the blue port, and you're going to let it look at the blue port. So off to yellow, on to blue. A couple of different ways of remembering, but the best way to check is when you look up at your waveform. When you look up at your waveform, you'll have your two little bumps, CVP looking waveform. Okay, when they come back from cath lab, what you want to do is you have your, turn it on, and it's going to go through its thing. It's going to go through its thing. And you're going to enter the height, and you can go inches. Oh, let's say our person is 5'8". And let's say for easy reference, let's say they're 100 kilos. Okay, then we're going to go continue. And this right here is already set up to read our cardiac index first. And that's what we want to do, is we want to look at our patient's cardiac index. Yes, the cardiac output is important, but our cardiac index is a little bit more indicative of what's going on with your patient. If you have 4 liters of blood flow per minute, a normal cardiac output on the lower end of normal. In a 6'5" person that's 250 pounds, that may not be enough to perfuse every little part of their body. It may be enough to perfuse in a 5'0", 90-pound little grandma, but that's why it's important to take a look at your cardiac index, because it will measure based on the patient's height and weight that we've entered. So the patient, when they come back, this is for the continuous cardiac output, 2 thermistor ports. This one, the blue goes to blue, And with this one, I want you to take a look in there. You have some pretty fragile filaments, and you want to be careful when you're attaching them. Line them up, and then you're going to screw this in. And as you can see, it's showing your blood temp, which that's honestly the temperature of the room right now. So that's how you know it works. When you get it set up in the patient, what you're going to do is you're going to turn the on off. And right here it's saying out of range, but this is the on off button to start your monitoring, and it'll say collecting data, collecting data. It'll say collecting data, and then you'll have your readings there. So that's our continuous cardiac output. Our manual is a little bit different. I'm going to go ahead and show that. Get this out of the way. Our manual, you need some different equipment. So in our manual, you need this that you get in our supply room. This fits into our monitor here. Just snaps in. And then you need a cable. The stuff is orange. The stuff is orange, so look for your orange. Orange goes to orange, nice and simple. And then you want to make sure you're taking a look at this. This is going to have 2 pieces to it. In your manual cardiac output, instead of the 2 thermistor ports, you have 1 thermistor port, and then this goes where you're going to be checking your manual cardiac output. Okay, so in this, I'm going to attach this to here. We would have stopcocks. This is our manual cardiac output. And what we're going to do is this is going to attach to here. Same thing, little itty bitty filaments. You don't want to keep disconnecting and reconnecting just because you don't want to bend those, and once you bend them, it's going to be next to impossible to get a reading again. So you attach this here, and this might already be bent. There we go. Okay, so this is going to show your temperature up here. So you're going to have your patient's temperature from the Swan. When you're doing a cardiac output with the manual, annoying, when you're doing it with the manual, you need this thing called a coset. And this is what you're going to do to get your cardiac outputs. You're going to inject the fluid with this syringe into the blue port. I'm going to show you how to set this up because it is a little bit different. You open this thing up. This and this go together like this. You can unravel this just because it's easier. Years ago, we used to have to ice these, but now we have much more advanced equipment, so you don't have to ice them anymore. But you would put this in a container of ice just to help things go through. So you take your bag, you can either use 0.9 or D5. I believe the most recent recommendation is to use D5. You're gonna spike it like you would any other IV bag. Okay. You're gonna spike it like you would any other IV bag, and I'm just gonna put this here for, let me scoot this out of the way so we can see it better. Okay. So in order to prime this, you just pull back, and you're gonna get rid of the air. Just keep going until you get it primed all the way. Okay. And don't forget about this little stopcock here. And make sure this is primed too. Fluid coming out of there. Okay. So this is going to go on the end of your swan right here. So right here, this is where you'll have your bridge for your CVP. This is gonna go on the end here. And if you have a maintenance fluid, you're gonna put the maintenance fluid on this stopcock here. So what I'm gonna do is I'm just gonna attach this here. So normally on a regular basis, when you're not checking your cardiac outputs, you'll have it like this. So your maintenance fluids are going through here, in here to keep your line open. When you are doing a cardiac output, you're going to have this like here so you can have a nice straight shot to fluid through here. Also too, when you're checking your cardiac output, when you first set this up, this is the little sensor that measures the fluid that goes past. So that's how that's gonna be. And what you're gonna do is when you're ready to do your cardiac output, you're gonna go in your menu here, and it has set up cardiac output. Standard, and then you're gonna say do a cardiac output, and it's gonna ask, it's gonna say ready for a new measurement, and when you're ready to go, you'll hit start cardiac output. And what you're gonna do is I'm gonna do it, I don't wanna put it in my swan, but what you're gonna do is you are going to pull out a full syringe. You're going to clamp this here. This supposedly is a one-way valve. In a perfect world, it's not gonna go back there, but you might as well just clamp it anyhow. And what you're gonna do is when it says ready for new measurement, you're gonna hit start cardiac output. It's gonna tell you to inject now, and you're gonna go as fast as you can, inject this here. And then you're gonna get a waveform here, and it's gonna give you a number right there. And it's gonna give us a funky number because I just wet the bed. You're gonna go through 3 of these. You're gonna go through 3 of these, and you're gonna get the average. And then in here too, you'll be able to do, once you get your cardiac output and your index, you'll be able to do hemodynamic calculations, and it'll give you a little bit more information than just your pulmonary artery pressures, your CVP numbers, and your cardiac output. It'll be able to give you things like your SVR, which is important, and I'll give you a quick basic on that. So we're gonna want 3, and it'll average it, and then we'll enter it when it's done. Hemodynamic calculation, you put that in there, and you just plug and chug your numbers. Just plug and chug your numbers, and it'll give you your numbers, like your your SVR and things like that. I think. So that is the manual cardiac output swan. There is one other swan that sometimes we see. These, if they're going for a right heart cath, a lot of times they'll use this swan. And then if they decide after all just to send them to the unit afterwards, you'll see this swan. Typically these are actually in a brachial. And the same concept here. Here's an injectate. This is where you can give this one, instead of your yellow port, it'll be white. So this is white, just like yellow and yellow. So this will be where you're gonna get your, this is gonna be where you get your PA readings. This is where you're gonna get your CVP readings. And then this will also be thread through a cordis. But like I said, it's probably gonna be in a brachial. So if you see these, and then this gets hooked up, just like a manual cardiac output would be also. Okay, so one of the next things we're gonna do is if we are going to discontinue the swan. We need to double check and make sure we have the order, obviously. And in our order, we wanna know, are we gonna take out the swan and the cordis, or are we going to leave the cordis? So I'm just going to go through if we would take out the swan and leave the cordis. There is, with every swan, there is this little blue piece, and this is going to go over your, introducer, just this little hole. In a perfect world, it is a one-way valve, and ideally things can't go in there once you pull out the swan, but just on the abundance of caution, we're going to put one of these blue caps on there. We have extra of these in the supply room, but whenever a swan is inserted, this should come with the kit. So once you have the order, you want to make sure you check the x-ray, make sure that there's no weird little kinks or knots in the pulmonary artery catheter before you take it out. But basically, you're going to take it out like you do any other central line. You're going to have the patient as flat as they can be. You're going to practice take a deep breath and hold it while you withdraw it slowly. So you're going to practice that. But the couple other things that you're going to do with it is the things that I've found that's helpful, just so they don't get all mixed up. I disconnect everything from my swan and make sure the stopcocks are off so you don't inadvertently get air in there. So basically it just looks like it's on the patient like this. Disconnect everything, stopcocks. You're going to want to make sure the balloon is deflated. This is in the lock position, this is in the open position, and you want to make sure that when you put it in the open position, air doesn't come out. And then what you're going to do is when you pull the swan, you're going to want to also look up at your monitor, because as it's going through the right ventricle, it may actually cause a little bit of ectopy. So you just want to make sure and watch for that. So what you're going to do is when the swan comes out, it's going to be in the introducer. So it's going to be in the introducer. It's going to be attached to your patient like this. And what you're going to do is when you pull this, you're going to tell the patient, take a nice deep breath. Actually, you know what? Sorry, it'll have to be redone here. So, okay, when the swan is in, it is locked like here. You have a little notch here. When you take the swan out, you're going to unnotch it. You're going to pull this off here like this. And when you pull the swan, you're going to do a fluid steady motion when you pull it. So you're going to tell the patient, to take a nice deep breath. You're going to do it sterilely. You're going to have sterile gloves on. And then this is going to be sterile also. It's going to be on your sterile field. So you're going to tell the patient, take a nice deep breath in and hold it while you're pulling it. And then you're going to look up at your monitor to make sure there's no ectopy. And then what you're going to do is you're going to put this cap back on here. And then this is going to fit into the little notch there. So this is nice and secure. And then you're going to redress this like you would any other central line. If you take out the swan, you really do need to take off the old dressing from the cordis. I have seen times that they try to just put it back on, but in infection control, standpoint, you want to just change out the whole dressing anyhow. So that's how you would discontinue the swan, and then just go ahead and document it like you normally would in Epic. A couple other things with the swan. You saw how there was that little notch there. I'm just going to put this back in here like this. Okay, with our swans, to check and see where they are, we want to see what type of level they're at. Okay, so if you take a look, the big line is at 50, the little line is at 10. So here, this is 50 plus 10 this is a marking of 60. This is a marking of 50, 60, 70. So when we're measuring the insertion distance of the swan, we are checking it right here. Where does it go into this thing? So this marking here, it's not quite 60, so you figure here, you're probably about a level of about 57. And that's something you want to document in Epic, and if the Swan migrates, that's important information to know. Is it in the same place? Is it a problem with your equipment? Or do you think your Swan actually has moved into a different place? A couple other things too with this is when you're securing your Swan to your patient. It's coming out of your patient here. You don't want this flapping around and accidentally getting pulled out. So this we typically tape to the arm here. But this also too, this keeps it sterile in case the physician wants to adjust it. So the physician can adjust it as long as this is in here. This is considered sterile on the inside. If he adjusts it here, it still maintains sterility. But when we're securing this, we don't want to put tape over here. So what you want to do is if it goes in, you're going to want to put the tape here and then put the tape here and then put tape over this, because if you put tape over this part, if you take off the tape or the tape gets loose, you could potentially cause little micro holes in there, and that would increase your risk of infection. Let's see, couple other things. Let's see, in a perfect world when we're measuring, I do just have to mention this, if the patient has a lot of respiratory variation on the monitor, you see your waveforms are here and then all of a sudden down here. If they have a lot of respiratory variation, the ideal place to do would be to check at end expiration. And there's a couple of ways to do this. Our monitors now are pretty good. They're able to get us a pretty accurate number, and honestly, I have not had to do the end expiration thing in quite a while. But what you do is, in a vented patient, think vented valley, ideally your PA numbers will be lower. Based on the pressures within the chest with inspiration and expiration. In a non-vented patient, it'll be higher. Another way you can do it is just put your hand on the patient's chest and watch as it goes past the monitor. When you feel them exhale at the very end of it, look where your monitor is. A couple of things on the monitor, when you're doing that, you can actually go in here and you can actually freeze your wave. And when you freeze your wave, there's a cursor that you can actually go up and down with to get a number. Now, like I said, a lot of times our monitors are so good we don't even have to do that, but that is something out there. If you have a question or concern, you can grab myself, you can grab one of the heart nurses. They're pretty well versed in Swans and can also help you do this. And then if you want to take a better look at your waveform, you can freeze the wave and take a better look at the waveform. And then when you're done, here, you'll be able to unfreeze it. Just a couple little things with this. And then let's see here. And then your scale. A lot of times, a lot of people like to do optimal scale. But sometimes what I'll do is if I'm checking a CVP, when I'm checking a CVP, you may want to change your scale just because you won't be able to see a good waveform. See, is this really a CVP waveform? The last thing I just kind of want to briefly touch on is with your Swan and your hemodynamics. And I do have a handout for that. Is basically our Swan is going to help guide our therapy. When we're looking at hemodynamics, you're looking at your heart rate. That's kind of pretty simple to do. Is it too high? Bring it down. Is it too low? Bring it up. But where the Swan is really going to help us is our cardiac output. And it's going to help us manipulate different medications and different things with our cardiac output. So when we're looking at our cardiac output, you're looking at the stroke volume. Our stroke volume is determined by our contractility. How much pump do we have? How strong is your heart muscle? Do you have a nice strong contraction, or do you have a big old boggy heart? If you have a big old boggy heart, you may need to give them a little bit of dobutamine. Preload. Do you have too much fluid in your system? Not enough. That can affect your stroke volume. And then too much, to diurese them, too little, give them fluid. Afterload. And that is something when you put in your numbers of your Swan, it's going to give you a number for your afterload, your SVR in your systemic, and your PVR in your pulmonary system. And if it's too high, you kind of need to tighten things up in the periphery. If it's too high, you need to kind of dilate everything. If it's too low, you need to kind of tighten everything up in the periphery. So basic stuff. You can always look at the hemodynamic book that Advocate has as a practice workbook to give you more information, or ask one of the heart nurses. The heart nurses typically do have a lot of this information that they can kind of help talk you through. And then one more thing, I wanted to go over the mixed venous. The mixed venous is it's about your microcirculation. So when you're looking at your mixed venous, it tells you what's going on at the tissue level. Cardiac output is just basically how much blood is flowing through. Mixed venous tells you what's going on at the tissue level. Is the blood getting to the tissues which your body needs? And what we're going to do is, when we're checking that, we take a look at our Swan and draw a number from the Swan. So what you're going to do when you do a mixed venous is you are going to put so what you're going to do is you're going to put a syringe on here on the yellow port. And you're going to withdraw with the syringe, and you're going to go slow because you don't want to over extract the oxygen. You're going to waste first, 5 to 10 cc's, and then you're going to draw it as a gas, and when you put in the order, it's going to be a venous gas, and respiratory will draw it. And then just make sure you're flushing your line afterwards. And you'll be able to tell if your line is well flushed, your blood is gone, and you'll have a good waveform back on the monitor again. And also double check your square wave test afterwards just to make sure it's still good. So looking at your SVO2, normal, 60 to 80. If it's low, somehow your tissues need more blood flow. More oxygen. So either you increase the blood flow, give them better blood flow, increase your cardiac output. They need more oxygen, give them more oxygen. Is your PO2 on your regular arterial gas is low? If you don't have enough oxygen in the blood, how can you get it to your tissues? And then also think about your hemoglobin. If you don't have something to carry the oxygen, how can it get to the tissues? And then also too, is it a demand issue? Are your tissues needing too much oxygen? Are they agitated? Are they using up all the oxygen in their tissues? Are they shivering? Do they have a fever? Fix that stuff. A high SVO2, I've very rarely seen it, but if you have a high SVO2, it might be because the tissues are so damaged they can't pull any oxygen out, or is your PO2 super high? Is the patient getting too much oxygen? Is your PO2 like in the 400s on your ABGs? So, any questions? Find me, talk to one of the open heart nurses. We have a multitude of resources. There's some really good advocate workbooks out there for both hemodynamics and then hemodynamic medications that are available with our education corner. So, thank you for your time.